Ladies and gentlemen, I'm absolutely delighted to introduce to you Dr. Sathya Rao. Now, he's a Platinum Club member. He's a Platinum Club member of the BPD conference, and I would say a frequent flyer of clinicians in this space. Can you please warmly welcome Dr. Sathya Rao.
Good morning. I'm indeed very happy to be here today. Several of my dreams have come true. One of my dreams was to have an Australian Borderline Personality Disorder Foundation, and it's been there for the last few years. And here we are at the 4th National BPD Awareness Day conference. I'm also the other dream of mine which has come true is I always wanted to make sure that we have a BPD Awareness Day for Australia. And thanks to Jan McMahon and Andrew Channon and others who have tirelessly fought for this, and I'm indeed very happy. Okay, now in the next 10 minutes, I hope to convince you that we clinicians really have no excuses not to treat people with borderline personality disorder. What treatments work? Now, plenty of good research has been done in the last couple of decades, and for those of us who work in the field of personality disorders, these are very exciting times. It's now quite clear that BPD is a common mental illness, as Andrew Channon put it, and it is an eminently treatable disorder. And I agree with Andrew that symptomatic recovery is something we are able to achieve, but symptomatic remission is we are able to achieve, but recovery is still a problem. Of course, there are no medications to date that are specifically indicated or patented for borderline personality disorder. Unfortunately, we use a lot of medications, again, as Andrew was pointing it out earlier on. Now, it's becoming more and more clearer that there are biological, psychological, and social factors that result in borderline personality disorder, like all the other psychiatric illnesses. Now, there are several specialist treatments, the branded treatments, as Andrew put it, and which have empirical evidence. I'm not going to go through the whole list, but as you can read, there is DBT, MBT, CAT, schema-focused therapy, etc., etc. Now, we also have a couple of homegrown treatments that are being researched, the Sydney-based conversational model and the spectrum-based acceptance and commitment therapy, which we need to do a lot more research about. There are about 20 randomized controlled trials, at least, in support of most of the specialist treatments. So there is a mushrooming of treatments for borderline personality disorder. This is very encouraging, but it is also very confusing to both clinicians as well as to patients and families. Hence, attempts are being done to integrate them and synthesize them. The good news is that there is good evidence that psychological treatments are effective for borderline personality disorder. It is also now clear that most people with the borderline personality disorder achieve at least symptomatic remission. It's been well demonstrated, as Roy was speaking earlier on, that it is cost-effective to treat rather than not treat. But try taking this argument to the politicians. It's a hard sell. Few people with BPD seem to require lifelong treatments like we thought before. Overall, there is therapeutic, the therapeutic nihilism of the past is being replaced with much more hope and optimism, at least for those of us who work in this field. But there are several challenges facing us. We know that at least 1% of the population suffer borderline personality disorder, there is significant stigma surrounding the disorder, as Andrew put it, and patients are often refused treatment. Our mental health services and public hospitals were basically set up to manage people with major mental illnesses such as schizophrenia and bipolar disorders, and they're really not ideal for managing borderline personality disorder. And of course, the sector is very grossly under-resourced, and we have a mental health workforce that is inadequately trained in the management and treatment of BPD-specific specialist treatments such as DBT, MBT, etc., etc. So given 1% of the population having BPD, we have at least 220,000 Australians who would potentially qualify for a diagnosis of BPD. And let's say that we were going to do a treatment such as dialectical behavior therapy for all this 220,000 people, we would require $3 billion per year, because it costs about $14,000 to do DBT. I'm clearly less optimistic that we are ever going to get that sort of funding. So given these facts, most people are going to be treated in the generalist public hospital settings rather than in specialist services such as Spectrum or High program. Now, if we were to be serious about organizing treatments for people with borderline personality disorder, we need to ask these questions. What should be the model of care for borderline personality disorder in public mental health services? One of my colleagues who is here, Dr. Kothari, is currently working on trying to develop a model for public hospitals for the treatment of borderline personality disorder. So do all those people who attract a diagnosis of BPD require long-term specialist and expensive treatments such as dialectical behavior therapy or MBT or one of those branded therapies? Or do we have less expensive, less intensive, but still very effective interventions that can be undertaken by the entire mental health workforce, both in the private and public systems? Are there generalist treatments that can be undertaken by the current mental health workforce with minimal additional training? One of the excuses most of us have as clinicians not to treat is that we are not trained. So what specialist treatments are indicated for what subtype of borderline patients? So these are some of the questions which we really need to be answering. Now, some of the latest developments in psychotherapy for BPD may help us answer some of these questions. When specialist treatments are compared, no one treatment comes out as superior to the other. That's very clear. Most of the specialist treatments have more commonalities than differences, and most of them have several common factors. Now, clinicians have often intuitively found that good quality general treatments yield positive results for BPD. Research is now beginning to prove that to be true. In research trials, specialist treatments have been compared with generalist treatments, and not surprisingly, the generalist interventions are strikingly effective and nearly as good as generalist specialist therapies. At least it is true in the context of research trials. So these are some of the generalist treatments. I want to particularly highlight one of them, the good clinical care. The good clinical care, this is a manualized treatment developed by Andrew Channon from Melbourne, and this has been compared with CAT, and it's been developed in the Australian context. So we could very well use this as a treatment option in generalist settings. However, it needs to be made very clear at the outset that by generalist treatments, we don't mean treatment as usual. Treatment as usual means just admissions and discharge, giving medications, seeing the CAT team, going to the emergency department. That's just management, and that's just treatment as usual. That's not going to work. What we mean by effective generalist treatments is they're treatments which are specifically developed for a borderline personality disorder. Now, further work has been undertaken. People have started to look at the common factors in all of the specialist treatments, so specialist meaning DBT, MBT, etc., and also the common factors in generalist treatments, those 4 generalist treatments which I outlined. And of course, the national guidelines, the Australian national guidelines, have also outlined general treatment principles. And many of the international experts have named features that they believe are important in the effective treatments of BPD. So, what we need to really know is that although there are several psychotherapy treatment options, what should we choose? Now, Livesley has captured the dilemma in the following statement. What we need to know now is what kind of interventions work with what kind of problems and what kind of patients. Now, following is my attempt at summarizing some of the common factors in all of the empirically supported treatments, the specialist treatments, generalist treatment, the NHMRC guidelines, and the expert opinions. And I firmly believe that most of our mental health clinicians already use some of these common factors, and it is easy to teach and train, but they need to be structured and systematized within the treatment context. So these factors can be summarized as the therapist factors, therapy-related factors, and other factors. In the interest of time, I'm going to only highlight a couple of these factors. The therapist factors are the therapists have to be adequately trained, they have to be supervised, and they have to be hopeful. And they should be willing to treat, and they need to be enthusiastic, and they need to be active and engaged in therapy. The therapy factors important ones are those having a clear treatment framework and having an agreed upon goal for treatment with the patients and having an agreed upon plan as to how the treatment is going to happen. Of course, they need to manage their own emotions and the emotions of the patients and focusing on change. Now, other important factors are the other important factors are the validation and managing crisis and balancing the limits and flexibility. Now, in conclusion, the factors common to empirically supported treatments for borderline personality disorder can be applied without major modifications to the current treatment approaches in generalist psychiatric settings where majority of the patients are going to be treated. The psychotherapeutic approaches that I have outlined, I believe, do not require extensive or expensive psychotherapy training and making it applicable across the field of psychiatry. General mental health clinicians are already highly skilled and are capable of delivering treatments for BPD, but they need to train themselves to apply these factors that I've just listed. So this offers hope that we may be able to not just manage, but actually start treating people with BPD, and without imposing excessive demands on resources within the context of our current healthcare systems. I'm all for attracting more funding, don't get me wrong, but I'm also I also want to be pragmatic. Now, what do we need to do? We need to, of course, continue to do this awareness day conferences, and we need to increase the awareness and influence and educate policymakers, funding bodies using platforms such as the BPD Foundation, awareness day and the conferences, etc. We need to implement the NHMRC guidelines, advocate for adequate training, and we need to actually call for a national training framework for a borderline personality disorder if we're really serious about it. And we need to start developing newer models for managing BPD in public mental health systems. Now, the take-home message, as Mary Zenarini put it, any reasonable treatment provided by reasonable clinicians in a reasonable manner may be beneficial to people with borderline personality disorder. I may quickly add that reasonable treatment does not mean treatment as usual, but specific treatments treatment factors which I just outlined. Therefore, we really have no excuses not to treat BPD, and I agree with Andrew Channon that treatment of BPD is not rocket science. Thank you.
Thank you so much.